All right, let's talk about one of the most critical respiratory emergencies you're ever going to face, the acute asthma exacerbation. Look, whether you're working a shift in the emergency department or you're studying for your finals, having a rock-solid, systematic approach is what's going to save lives. So let's break it all down.
So picture this. You've got a patient who is in obvious distress, just gasping for air. This is a scenario that's going to come up again and again in real life and on your exams. Your ability to stay calm and think clearly, well, that starts right now.
Okay, first things first. When someone is acutely short of breath, you've got to think broadly before you narrow things down. It's all about building that differential diagnosis in your head and then, really quickly, finding the clues that point you in the right direction.
Remember, not being able to breathe isn't just a lung problem. The cause could be cardiac, it could be renal, it could even be something like severe anemia. Our first job is to sift through all these possibilities. We're basically detectives, hunting for the specific clues in the patient's history that just scream asthma. And that story is your gold mine. Is there a pattern here? Recurrent episodes where the patient is totally fine in between? Is a wheeze the main thing you're hearing? Do things get worse at night? And what about a personal or family history of atopy? Things like eczema or allergic rhinitis. These are the questions that are going to move asthma right to the top of your list. Okay, so you're thinking asthma. Your very next move is to figure out how severe this attack actually is. And this isn't just for the charts, it's a huge decision point. It tells you exactly how aggressive you need to be right this second. This table lays it out perfectly. A patient who's talking in short phrases, they're agitated, their heart and respiratory rates are way up, that's severe. But when they can only get out single words at a time, or they start to get drowsy, or, and this is a big one, their chest goes silent, you're in life-threatening territory. A silent chest is terrifying. It means so little air is moving, you can't even hear a wheeze.
And if you want a hard number, here it is, a peak expiratory flow, or PF, that's less than 60% of what it should be. That's your objective, undeniable proof of a severe or even life-threatening attack. Now, you have to remember this. This is so important. A patient who is agitated and fighting for every breath, who then suddenly gets quiet or drowsy, is not getting better. They are getting tired, they are crashing. This is a massive sign of impending respiratory failure, and you are officially running out of time.
So what do we do? Well, your initial response has to be systematic, and it has to be fast. There are 4 things that need to happen pretty much all at once as soon as you know you're dealing with a severe attack.
I want you to think OSAS, oxygen, salbutamol, anticholinergic, and steroids. Get the oxygen on immediately. You're shooting for oxygen sats of 93 to 95%. Then start back-to-back oxygen-driven nebulizers with your bronchodilators and get those steroids on board to start fighting that underlying inflammation.
Just a quick note on steroids. The evidence is pretty clear. Oral and IV work about the same. So, for most patients, oral prednisolone is totally fine. But if they're too breathless to swallow, if they're vomiting, or if they need ventilatory support, that's when you go for the IV hydrocortisone. Simple as that.
So, you've done all the first-line treatments. You've hit them with everything. But the patient just isn't getting better. They're still struggling to breathe. Their numbers aren't improving. It is absolutely time to escalate care.
Recognizing early that your initial plan is failing is a critical skill. This is the point where you call for senior help, usually from anesthetics or intensive care, and you start thinking about that next layer of treatment.
So your next moves are happening at the same time. You're starting an IV infusion of magnesium sulfate. It's a great, smooth muscle relaxant. And while that's running, you're investigating. Could there be a complication, like a pneumothorax? Get that chest x-ray. And most importantly, get an arterial blood gas to find out what's really happening with their gas exchange.
An ABG gives you the ground truth. A low oxygen level, well, that confirms they're hypoxic. But the real red flag, the number that should make you sit up straight, is a rising carbon dioxide level. See, at first these patients are breathing so fast they blow off CO2. So if you see a normal, or worse, a rising CO2, that's an extremely ominous sign. It means they're tiring out, they're failing to ventilate, and you have to start thinking about intubation now.
And if you do have to intubate, this is a massive concept for anyone in anesthesia or ICU. Your number one goal is to avoid this, dynamic hyperinflation. Their airways are so tight they can't get the air out fully. If the ventilator pushes the next breath in too soon, you trap more and more air, the pressure in the chest builds up, and that can lead to total cardiovascular collapse. Your entire strategy has to be built around giving them a long time to exhale.
Okay, the patient is stable, they're improving, the acute danger is over. But your job isn't done. It just shifts. You go from crisis management to making sure this never, ever happens again.
So what's the ultimate goal? It's not just about surviving the attack. It's about achieving complete control of their asthma. That means no symptoms during the day, no waking up at night, no needing a rescue inhaler, no limits on their life. And normal lung function. That's the benchmark we're aiming for.
Before any patient goes home, it's absolutely essential to figure out why this happened in the first place. And as this quote says, it often comes down to the basics. Are they using their inhaler the right way? Are they actually taking their medicine? Fixing these simple issues is probably the most powerful thing you can do to stop them from coming back.
And that really brings us to the biggest challenge of all, doesn't it? We have amazing, effective treatments for asthma. So why do people still end up in the ICU, fighting for their lives? The answer really goes beyond just the medicine. The real work is in managing a chronic disease, day in and day out. And that requires a real partnership between you and your patient.
So we've pulled all this information together from peer-reviewed articles and clinical protocols to give you this guide. We really hope it helps you out in your practice. Thanks so much for joining us.